Good evening, everyone. It's Dr. Towfigh. Welcome to Hernia Talk Live. We're here again on a Hernia Talk Tuesday night. My name is Dr. Shirin Towfigh. I am your hernia and laparoscopic surgery specialist. Thanks for everyone who's joining me on Zoom as a live and also as a Facebook Live. You can follow me on HerniaDoc on Instagram and X. But most importantly, I do want you all to subscribe and follow me on my YouTube channel where all of these episodes and prior episodes are archived. We're also on as a podcast if you prefer to listen to Hernia Talk Live as a podcast. So we got tons and tons of great content for you. So I'm really excited because Clayton Petro, Dr. Clayton Petro is our guest today. He is a very lovely surgeon, part of the esteemed Cleveland Clinic hernia group. He is one of their hernia surgery specialists in Cleveland, Ohio. And I'm super excited, and you'll know just why once you hear him talk. Thanks so much, Clayton, for joining me.
Yes, absolutely. Thank you for having me. I'm honored to be here.
Thank you. So Clayton's one of the younger surgeons that I have the pleasure of having. But I felt that I was very impressed by your empathy for both the surgeons and the patients. We were recently in Cleveland, in your hometown, for a course we were teaching for the fellows that are in training to do laparoscopic hernias and minimally invasive surgery and so on. And what did I talk about? I talked about I think going into private practice.
Correct. Yeah.
And you gave this really amazing talk about handling complications, because as someone graduates from their training, now they're responsible for the complications that will occur. Every surgeon will have a complication. There's the old saying, right? If you have no complication, either you're not operating, right?
Yep.
You must not
Yep.
be operating, because all surgeons will have a complication. It's just you can't not have it. But it's very humbling. I recall my first complication. I was a county employee, so I was at the county USC, and I think back at it, it's just so funny. So I did a laparoscopic cholecystectomy, right? Gallbladder surgery, very like routine surgery. Everyone who graduates from their general surgery should be able to do a good gallbladder surgery. And at the county hospital, that's like all you were doing, pretty much. It's like 80% of the operations were gallbladder surgeries. And I got my first complication was a bile leak.
Ooh.
And I was junior. Everyone was like in their 50s or over in my group. And I was like just hired right out of residency. And they had our own little group M&M, and I had to expose myself. I felt like exposed that I had this complication. I literally thought the world had just ended, and I'm just going to be like labeled as the worst surgeon ever. And for most of you, if you don't know, a bile leak is, I mean, it can be a disastrous problem. In this case, it wasn't. It was just like a little ductal kind of leak or something. We didn't even have to do anything for the patient. It just stopped on its own. Um, the like lab test was abnormal for a couple of days, and there was a little fluid. Everything else was normal. But to me, I felt like a failure. I felt like they're just going to be like, wow, look at her. She just came out of residency and already she's causing complications, which of course wasn't the situation. But to me, in my little world, it was, I felt really exposed.
100%.
So I don't
Yeah.
know, have you had that experience too? Everyone has
Oh,
complications.
absolutely. Yeah. I mean, I started my career at the main campus of the Cleveland Clinic
Oh
at a
boy.
time where a lot of the senior staff had left to take leadership positions at other hospitals, and the
Mm,
department was, kind of turning over a little bit. And so we were taking a lot of call. They hired me and the HPV fellow the same year, and we were both, new staff taking a lot of call. And so you can imagine the types of cases that the main campus of the Cleveland Clinic attracts. No one has a straightforward anything. It's
no.
they
You
have their
travel for all your work, yeah.
yeah, and in the straightforward cases, they're either 100 years old, or they've had a heart transplant or something.
Yeah.
Everyone has something. It's never just an appendectomy or just an inguinal hernia.
Yeah.
It's always got something else going on with it. And Same thing. I mean, I remember the first inguinal hernia I fixed was not the first one. The first complication I had was on a patient who was like 98 years old,
Yeah.
inguinal hernia, and he aspirated in the recovery area.
Oh, so that basically the stomach contents land in the lung, and that could
Yeah.
be,
Yep.
that's really devastating for an older patient.
Older patient ended up in the ICU. And so that was, again,
From an inguinal hernia.
from an inguinal hernia.
Yeah.
So, and again, this is, and it's hard. And I think the hard part and the reason for the, talking to the fellows too, is just you are the person, like, whether it's related to surgery or not, anything that happens to your patient while they're in the hospital, you're the point person, and the family's waiting to hear from you. And that was part of my talk was, in talking to the fellows, was to make sure, they understood that that family in the waiting area, whether it's related to surgery or not, they're waiting to hear from you, and you need to see those patients multiple times a day because, you know, nothing is worse when a patient's going through a complication than when the surgeon retreats. And I think that we have to recognize that as surgeons, and those are the patients that you need to, have the patients need to be able to get a hold of you. And so
Yeah.
oftentimes when I was a junior, I took that to heart, and maybe I even took it too far. And I would, give those patients my cell phone number, and for the first couple of years, I think the story I told before was like I gave patients my cell phone number, and most patients are respectful of that, but
They
some
are.
people,
They really are.
they
Yeah.
really are. I've actually been shocked. Like most patients, like if there's an issue, I want them to be able to get a hold of me because, big hospital system, particularly like the Cleveland Clinic, you're getting into a call tree and it might be hard to get a hold of someone. And there's, when someone has had a complication, I feel like, they deserve a little more access. And so, most patients take it to heart, but there have been people who, you know, they're a call and text away all the time, it seems. So, but yeah, that was the gist of what my talk was about, was just making sure that patients know that you're there for them, particularly when they have a complication. Because if you see a patient through, complications happen, it's just part of surgery. And I know patients sometimes don't like to hear that. But the truth is that any operation, even no matter how routine, things happen. And I
Yeah.
think it's important to when they do happen, that you need to own it, and the goal is to get them through the complication. And every complication has an end, and your job as the surgeon is to get them through it and see it through.
And I think so what I liked was that you actually addressed it. That's not a topic that's usually addressed with trainees. Um, but also you brought in the patient perspective too. Maybe you can talk a little bit about the patient perspective and like your
Sure.
approach with that.
I'm not sure exactly. I think I know what you're talking about, so hopefully
Like what, like how do patients maybe perceive, do you think they perceive complications, and how should a doctor kind of handle that?
yeah, I mean, the assumption is that, sometimes from the patient's perspective is that you did something wrong. Like
Yeah.
you must have left the operating room and something was wrong, and you missed it, or you did something, and that, depending on the medical literacy, like that is hard to convey sometimes, that like, listen, when I was there, everything looked okay. I did all the maneuvers that were necessary to
Yeah.
make it safe, but sometimes things happen, and that could be really challenging. And then the other kind of thing is just from the patient's perspective is, you know, most patients when they have their surgery, they envision what the recovery is going to look like, and they have these kind of checkpoints in their mind of, I'm going to be in the hospital this much time. I'm going to
Mm,
be out of work this much time, and I'm going to be back at work, and I'm going to be 100% by this day.
yeah.
And so when complications happen and that timeline gets disrupted, not only can it be frustrating for them, but the domino effect of how that can impact their life, we
True.
often don't always completely think about, in terms of, all of a sudden they were planning to be back at work at 4 weeks and now it's 6 weeks, and they may not have that PTO, and there's a financial consequence
Right.
that may not just be the hospital bill, but just the time that they took off work that they weren't planning, or they had childcare arranged for this many days, and now it's going to need to be longer. Or maybe there's someone that takes care of a parent, and they, are hiring someone else that has to do that role for them. So there's so many domino effects that we don't always think of. And so I think it's an important thing when we talk to patients of explaining, like, hey, listen, in a perfect world, this is the recovery, but these are X, Y, and Z things that can happen that may delay that recovery as well.
How do you talk about complications? So like for me, I do go over complications, but if something's really, really rare, like death, I don't
Yeah,
usually talk about death in
no,
like an inguinal hernia, right?
no,
Um, it's not, my patients tend not to die. I'm just not that person that's doing these like really sick patients or highly emergency operations. It's mostly elective. I mean, I'm happy to do them, but that's not usually what I do. Um, but then what if you do have a death or you do have a really bad complication? Do you ever feel like, does that
so
make you want to talk more to patients about all the complications? I feel like I
I
don't
could
want to
be,
stress them out with, because I
yeah.
understand the relative importance, but they may not understand, like, relatively speaking, what's important,
Yeah.
what's not of all the complications.
So I agree with you. I don't bring up death because I think I do think, and I could be wrong, but I think that there is just a common understanding that any operation carries a small risk of something horrible happening. And
Yeah.
I think in lay terms, most people appreciate that. I think what I talk most about are um things that are most common to our operations that people may not necessarily think of. So I think if you do something at a high volume and there are specific things that patients probably aren't aware of. So a perfect example of this in my world, I do a lot of big open abdominal wall reconstructions. And
Mm-hmm.
those are folks that need a big laparotomy. Often I'm taking old mesh out because people have had 2, 3, 4, 5 repairs,
Yeah.
and I'm doing it for the final time once and for all. And so one of the most common things that happens after these repairs is an ileus. That's probably the most common complication. And for
Yeah.
those who know, an ileus is delayed bowel function, and it means you throw up because you haven't passed
Get
gas, or
bloated,
and you get,
cramping.
yeah, and you get a tube in the nose, which is
Yeah.
the absolute most miserable thing in terms of recovery. And
Yeah.
so in our practice, it tends to be, 10-15% of folks. So it's not infrequent. And so I bring that up because when it happens on the third day and it prolongs their hospital stay by 3 or 4 days, and they're sitting there with that tube for the third day and they haven't passed gas or had a bowel movement yet, they're looking at you like, what's going on? Like, I should have been home by now. And so
Yeah.
I have learned that, because that honestly, that's the moment. And I know that the tube's going to come out. They're going to pass gas. They're going to have a bowel
You see
movement.
the light at the end of the
I
tunnel.
know they're going to be fine and in
Yeah.
the long run, but they don't know that. And so I have started to even bring that up in my office that, hey, listen, there's a chance this can happen. It's not the end of the world. It doesn't impact your repair long term. And so that's a perfect example of something that I bring up in the office just so they hear it. Usually I want their family to hear it because, again, that they're the one that is like, gosh, they thought they're going to be out of there by now, and now they're here a little longer. And so, but like wound morbidity, I'll comment that, our wound infection rate is somewhere around 3 or 4%, and that very rarely does that require going back to the operating room. And even if it does, it in the vast majority of cases doesn't impact the long-term durability of your repair.
Mm-hmm.
And so those are probably the two big things. Um, I don't bring up transfusion because I that's kind of
Blood
something that,
transfusion. Yeah, that's
yeah, I mean,
rare.
that's might be something I bring up in the moment, in the instance when it's necessary. Um, so
Yeah. Here's a question. It says, how do you address a situation where a patient seems to be worsening over time?
yeah, so that's a little vague, but I'll just kind of say, I think, in a scenario where, let's say, again, I'm trying to think of a scenario. So let's say someone has a respiratory trouble a couple days after surgery, and they're getting transferred to the ICU, and now they're reintubated. Again, I think with any complication, particularly if the patients are, let's like say, intubated and sedated in the ICU, it's you and the family, and it's you and that family is relying on you for updates, and it's really just about open lines of communication, honesty about what the trajectory is, honesty about when you're not sure. So if you're
Mhm.
not sure how long, the recovery is going to be, you can, just be honest. Don't give people unrealistic expectations of, oh, they'll probably be able to extubate them tomorrow and they'll be fine. So I think realistic
Yeah.
expectations about what the trajectory of the recovery will be like. If I feel like I have a good idea that of what someone's recovery is going to look like, I'll lay that out for them so they know. And I won't necessarily put dates on it, but I'll say first this has to happen, then this has to happen, then this will happen, and then they'll be ready to go. And I think giving people those kind of milestones lets them know over the next, course of the next week, where they're at in the recovery process.
What I like to do is kind of bring the patient into the whole process. And first I ask for their patience because, I can't predict the future. I can't say that I know every single answer. And so, be patient with me. We'll figure this out. I'm here. Also kind of remind them that I'm not just going to leave because there are doctors that kind of like, I'm done with you. Go to pain management or, hernia's fine. Just go home.
Yeah.
And the patient's like legit saying there's something wrong with me still, and they feel like they're being abandoned. So I never want the patient to feel abandoned in any way. Um, but I'm a bit realistic. Like there are maybe situations where I don't know the answer yet. It's going to take time for whatever the problem kind of to evolve, and so I can help figure it out.
Mhm.
So that's I always ask for the patient's patience.
Correct. Yeah.
In
And,
the
and I
process.
think
It's a process.
And I think another thing too, in the kind of the other end of the patient's coin is like, if you're going to say like, for instance, okay, I know you're having a little bit of pain after your inguinal hernia repair.
Hmm.
It's only been 2 weeks. Why don't we see how it goes? And why don't I see you in, this date, just so they have something in their mind. And you could tell them, hey, listen, if you're feeling better and it's gradually going away by then, you can cancel this appointment. But why don't we just have something on the books
Yeah.
just in case you're not getting better? And
Yes.
such a comfort to them. And
True.
even when people like, let's say, watchful waiting type scenarios where someone has a hernia, it's not that symptomatic, they're thinking of putting it off, they're not really sure they want to have surgery, they have a bunch of comorbidities. Those are the patients who I'll say, why don't we make an appointment for just 6 months from now?
Hmm.
Comes up and you don't want to make it, I'll go home early.
Fine.
Great.
Yeah.
And if you want, that way you just have something, you'll know that you have that appointment on the
Yeah.
book, and we can touch base again.
I agree with you. Yeah. Providing that follow up, just a double, triple check is good. Um, Here's a question. We had David on Kurpada, Dr. Kurpada's,
Mhm.
who's really kind of been having most of the groin pain part of your clinic. But
Mhm.
can I ask you a groin pain question?
Yeah, sure.
Okay, all right. So this is a patient question. Could you please address sexual dysfunction for men after mesh surgery? I've been having dysejaculation since a TEP inguinal hernia repair, so laparoscopic inguinal hernia repair TEP technique with
Hi.
mesh that was performed 7 months ago, and it's not getting better. I've never had this before. The urologists say they can't help, then that I'm a rare case. I was born with only one testicle, and that testicle is on the operated side with the hernia. Can these problems be resolved, or is it considered permanent damage? Should I consider mesh removal? I would like to get my sexuality back. Imagery doesn't find it much apart from a displaced spermatic cord, which is a finding actually, and high scar tissue inflammation around it, which also is a finding. I feel sexual problems from men in post-surgery are very seldom addressed, despite many of us having these symptoms. That's true. I actually had a patient advocate who's male come on this show, specifically saying, I feel like all these mesh issues are being addressed for women, and then the men are kind of left without much direction. So I have some comments about this, but what would you like to say about
So,
these
Um,
conversations?
you said it's been 7 months
7 months post-op from a lap
and
tap.
a lap tap. Okay. So, I mean, again, this is not my particular area of expertise, because we're fortunate to have David Kurpada who
Yeah.
handles a lot of these complex cases. But I will say, like, just in general, uh, there are things that happen in the human body that sometimes we just don't understand. All right. And I think that if you put a foreign body inside of someone, and I'm someone who puts permanent material all the time. So this isn't against, permanent material. The
Yeah.
vast majority of people do get benefit, and that's why we do it. There's a risk benefit ratio. But
Yeah.
there are things that happen in medicine that just people don't understand. And if the bottom line is if that mesh was put in and you've lost that type of function, that timing, of course, you're going to make that connection. And so I'll just say this, if it were me, or if you came to see me, I would say that, once I would probably give it more time. I might give it a full year, just to see if it was something that went away on its own. But if it did not, then I would just offer to take the mesh out. And again, the caveat being, and I think just being at the clinic, that we tend to do things just because, oftentimes, like, folks like yourself have been to many doctors, and
Yeah.
they feel like they're at their wits' end. They feel like no one's listening to them. And so I think that someone has to be willing to do these types of things, with the caveat that, like, that, hey, listen, like, I will do this, but just understand, I can't guarantee that the consequence is going to be that you're going to get your sexual dysfunction back. I do things like that all the time,
Yeah.
where,
Yeah.
and I do too, Sherman, where it's just like, I'm willing to do this just as long as we're on the same page of, like, I can't guarantee that it's going to help.
Yeah, I would say what he's saying is, this patient's saying is exactly right, which is there's not enough so the urologists don't really understand what we do surgically, and so they'll ultrasound the testicle and be like, "Oh, good blood flow, no epididymitis, you're good." And then the hernia surgeons aren't really understanding like the urologic and sexual function part of it. So your general surgeon, perhaps, who did the inguinal hernia repair, may be like, "You don't have a hernia recurrence, we're good." But
Mhm.
what happens is, especially with laparoscopic surgery I see in men, one of two things happens. Either there's too much overlap of the mesh with the spermatic cord, and so that can cause testicular pain and so on. Or what they sometimes do is the keyhole technique, where they wrap the mesh around the spermatic cord, and that could be very, very painful if it starts eroding into the cord, and that erosion can cause erosion to the vas, which makes ejaculation very painful, for example. So this finding of a lot of scar tissue and a displaced spermatic cord, maybe because that keyhole technique was used, and the only way to treat that is to remove the mesh. Or B, the way that the hernia was repaired is now making the trajectory from your testicle to your prostate kind of abnormal. So I've seen like kinked cords, right? Like it's kind of goes up and then it makes a little L before it gets, because of the way the mesh was placed. In any case, technically speaking, the sexual function has not been altered because the nerves and all that are normal. It's just it's the scar tissue and the interaction with the mesh. So these findings on imaging are real. Those are not much findings. It's actually quite a bit of finding already that someone's been able to figure out. And usually you need the mesh and the spermatic cord separated to address it. The good news is testicular function should be fine, and the ejaculatory function should be fine. It's just with pain plus this interaction with the mesh, you are distorting the anatomy to the point where you're getting pain. And I'm not sure well, I guess disejaculation would be the right term. It's just very painful because the vas may actually have an erosion or kinking where the spermatic flow is disrupted. So it's treatable. The good news is treatable. Okay, next question. Uh, is it common to have a sinus arrest for 30 to 45 seconds with carbon dioxide insufflation during laparoscopic surgery of the extraperitoneal area? And what are the reasons for that?
Um, so extraperitoneal dissections, I guess technically a TEP would be, so that those have been around a
Yeah.
while. That
Yeah.
has become a lot more common because with the robot, the extraperitoneal dissections have kind of gone up tremendously. And so we're
Mhm.
doing it for ventral hernias as well.
That's
I,
true. Yeah.
I have I have not, and so the higher up you are, I think the more likely that insufflation in that plane will tend to creep into patient subcutaneous tissue and may have consequences like PCO2 increasing.
Mhm.
I have not heard of, I haven't even heard of case report. I feel like that's the kind of thing where, it might be posted on IHC or something like that. And I have not heard of like incidents like that. And so
But there are situations where when the patient is, let's say, low volume, right? They've been fasting for surgery for a while, and then and then you quickly add pressure to the abdominal wall, right? That can kind of drop your blood pressure, I guess.
intraperitoneal, yeah, because
Yeah,
it's IVC collapse, yeah, absolutely.
yeah,
But extraperitoneal, I have actually not heard of that.
yeah, not as common. Yeah, I agree. Um, this says that Dr. Petro mentioned his infection rate. What is the timeline for an infectious complication to occur? If you're a patient who travels to have surgery, and this is a very good point. If you have a patient who travels to have surgery with an expert, such as yourself, how long should you plan to stay at a hotel so if the infection occurs, it can be addressed by the operating surgeon in the city of travel?
This
Excellent question.
this is such a great question.
Yeah.
And so this comes up all the time because folks travel from all over. And what I tell them is usually I will keep folks in the hospital maybe a little bit longer. I might, especially if they're traveling, you might give them an extra day or two in the hospital.
Mm-hmm.
And when they leave, I kind of put it this way. Depending on the time of year. So obviously, if you have to worry about snow and getting to Cleveland, depending on the
What's
time of year.
snow? Snow.
Yeah. So depending on the time of year,
Like if the sun shines a little bit too much.
yeah, exactly, or not enough. And then how far they have to go. So folks that have a 3 or 4 hour drive to West Virginia, I might say, okay, listen, you can go back, but just understand if anything happens in the next week or two, you got to drive all the way back. 3 or 4 hour
Mhm.
drive, usually I let them go home if they're
Yeah.
coming. Because the other thing you have to take into account is just what their means are. Like, can they afford to stay in a hotel or an
Yeah.
Airbnb for a week, or do they have family in town or something like that? If they have
Right.
family in town, I'll be like, just stay with your family for a week. Like that'd be great. I
Mm-hmm.
can see you in the office, maybe next week or 10 days later, and then after that, because usually you want to see someone about 2.5 to 3 weeks. Usually by 3 weeks, if the wound looks good, you're probably fine. So if
Yeah.
I keep so like the folks that are flying in, it's usually again, these are for bigger cases because that's usually why
Yes.
they're coming here for flying in. So it's a week in the hospital. It's why don't you stay in town for 2 weeks, and then if everything looks good 2 weeks after discharge, I feel comfortable with going. The folks going on the back. Some people do leave before that and just understand, listen, that's fine. If anything happens, you got to come back. Or, if I happen to know someone in town where I can, have them go see someone else locally.
Yeah, the good news is we're all very well connected, so we're friends and we'll help each other out. But I feel guilty if I operate on someone from a different state. Let's say I operate on someone from Cleveland, right? And
Yeah,
then they go home, they have a wound
yeah,
complication. I'll be like, Clayton, can you take care of my wound complication? I mean, I would
absolutely.
do it. I would take advantage of that, but I would feel
Yeah.
guilty, right?
Yeah, no, but I don't think, I mean, I've had that happen. This actually I just sent someone home this week to St. Louis, and I sent an email to Jeff Blatnick, and I was just saying,
Yeah,
hey, I'm sending this patient back. She says she can't afford to fly back.
yeah,
If anything happens, you're on the hook.
yeah,
Yeah.
yeah. It's a problem. Um, Here's some more. Prevention of seromas. If as a patient you are covered in mesh from groin to groin, i.e. you have additional groin surgery, is there a requirement to insert a drain to prevent a seroma? Do you
Um,
ever, are there any situations where you would place a drain to prevent seroma for groin surgery, no matter how complex?
for groin, the only scenario I leave a drain for groin folks is if they have ascites, because they have cirrhosis.
True.
That's the only scenario where I mean, you have everything working against you, particularly gravity,
Yeah,
and and
that's right.
that's the one scenario where, and I don't, to be totally honest, I don't even know if it helps sometimes. But that's the one scenario I do leave a drain. Otherwise, I don't routinely for inguinal hernias, even if it was bilateral, I don't routinely leave drains.
I'll tell you the times when I do put drains, which is also rare, would be if I'm shaving mesh off bladder because bladder can bleed,
Mm.
and you don't want, because you're closing the space, you don't want blood to accumulate in a space where you just place mesh because it can lift the mesh off of your repair.
Yep.
So that's the only time that I do it. It's
Oh,
a bladder
I would
involvement
say like
for
very,
mesh
very
removal.
large inguinal scrotal that where you're having to do like an open stopa type repair.
Yeah,
Like in the scrotum, I will just leave a drain.
yeah, because that space is now empty.
Yep.
Whenever it's empty space, it's at risk of filling up with fluid or blood. Another
Exactly.
seroma question, treatment of chronic seromas. What is the standard treatment to treat chronic large seromas, either of the abdominal wall or the groin? Do you allow the body to absorb the fluid, or do you insert a drain to shorten the time period and discomfort? Good
Yeah.
question.
It's a great question, and there's a lot of nuance in that question too. So it
Yeah,
sounds like the person is pretty experienced. So
yeah.
I'll start with the ventral. So the ventral post-op seroma, where the patient feels the bulge.
Mm-hmm.
It's not infected. Incision looks perfect, and
Mm-hmm.
it doesn't bother them. I will
Mm-hmm.
probably leave that alone. That is the most common scenario. And in those cases, again, you just want to leave it alone if you're lucky enough that that fluid collection is not infected. In most scenarios, the body's just going to chew it up.
Okay.
If it becomes chronic and the fluid collection's there and it
Like
bothers
six
them,
months later,
yeah, like 3 to 6 months later,
3 months
if it's
later.
still there and it bothers them, then I'll just open it up and I'll cauterize the cavity and then
Mm-hmm.
usually leave the drain closed and eventually it will go away. Um, or sometimes just have IR put a drain in it.
The
Um,
interventional
but if
radiologist, yeah.
if it's chronic, you're probably going to want to take the capsule out or
Because the
cauterize.
capsule will just
Yeah, it's just going to keep.
continue
Yeah, it's just going to keep
producing
filling up.
fluid. Yeah.
Exactly. So usually we'll just do that open. If it is post-op and it's super painful, I think then in that scenario I would drain it, and I would probably have IR put a drain in because it probably hasn't formed a capsule yet. Yeah, particularly because I tend to
We
take
just
the
go through the
sac.
scan, the interventional radiologist
Yeah, I would have the radiologist
ultrasound or
put a
CAT
drain in
scan.
because usually I take the hernia sac out so that capsule isn't there, and so if the capsule hasn't formed yet, I don't feel like I have to open it up all the way, unless it's infected.
Hmm.
So I would just have the radiologist put a drain, let it scar in, and then you're probably fine. Honestly, even if it is infected, sometimes you can just do that and give the antibiotics, and it's fine as long as there's no cellulitis. In
Yeah.
the groin ones are hard. The
Because the
groin,
scrotal skin doesn't, it's so elastic, it
yeah,
provides no external pressure. Like the
yeah.
abdominal wall, it's like, it's a little, it could be tight, you know?
Fortunately, the groin seromas typically aren't that painful. And so typically people will say, yeah, I feel a little bulge here, but it's different than the hernia and it doesn't bother me. And thank God, because that's a really common scenario. And I usually even will tell most patients with a sizable inguinal hernia, when I fix the hernia, that is like you said before, it's just an empty space now, and the body fills empty spaces with fluid. So you might feel a bulge there. It's just fluid. Eventually, it's going to gradually go down over the course of a month or two. Um, every once in a while, I mean, can think of 1 or 2 times in the last 5 years where not only has it been there, but it's been exquisitely painful. Um, I don't know what your experience is, Sharon, but draining them in the office, they just seem to come back.
Yeah.
In your experience, yeah.
Yeah.
And so I have actually once or twice just gone and made 2 small incisions and left either a vessel loop or a penrose to let it drain. And usually I might do like a week of prophylactic antibiotics just so the mesh doesn't get infected. And that seems to work the best.
Yeah, the key is prevention in those. I have
Yeah.
this whole wrapping technique where those big hernias
Yeah.
that they get basically a jock strap
Mhm.
with either lots of gauze, or just tell them like take tube socks so that you're just extremely compressing. And then on top of that, they wear a compression underwear, like a base layer, like an athletic men's underwear. And that tends to be a good prevention. But once you get the fluid, especially if there's blood in it, that's very heavy and there's a lot of discomfort in it.
Mhm.
Yeah, agreed. Okay, more questions. What lifestyle changes do you recommend to decrease inflammation systemically and reduce chronic pain associated with areas of hernia repair, specific adhesions? Is there anything you do to reduce adhesions from your big abdominal wall hernias?
No, not
No,
really.
yeah,
No.
yeah. I mean, there are things you can put to reduce adhesions for the bowel. Um,
Like Seprafilm or something?
Film and Intraseed. Do you use Intraseed?
I don't.
You
I
should
don't.
consider it. It's basically Film, but it feels like Surgicel, so it's like a fabric, so much easier to handle, especially laparoscopically.
Yes, as you know, Seprafilm is just a nightmare to handle.
It is, but Intraseed is not. It's just like fabric. It's like
I
Surgicel.
I will say that when I take down adhesions, I always mobilize the omentum completely because at the
Yeah.
end, when I take the towel out, I always just want the omentum. I usually pull the towel out and then I take the bottom of the omentum and I put it in the pelvis. So that way the omentum
Yes.
is covering everything, which
That would
is
be ideal.
how God wanted it. Like, and so because you have your posterior sheath closure, a lot of the repairs we do, I know this is really kind of getting into the weeds, but we're putting mesh between layers of muscle so that the mesh isn't, for the vast majority of big
Hmm.
cases, so the
Hmm.
mesh isn't rubbing up against the intestine. And so, but you still have that layer of muscle that thin layer that you're covering the bowel with, and you're
Hmm.
sewing that together. And so if anything's going to stick anywhere, it's going to stick to that layer that you were
That's
manipulating.
true, which is a good thing.
So if you take the omentum and you cover the bowel, the omentum is just this big fatty veil that covers the intestine. And if you have that kind of covering your bowels like a little blanket, that's I call that God's towel.
Yeah.
So that way you have, something, and that way if anything wants to get stuck up to the layer that you were manipulating, it's going to be the omentum and not the bowel.
Yeah, I think there's something I learned about too. It's called icodextrin. I don't know if you've heard of that. What's the brand name of it? It's but also made by Baxter, the same as um Tisteel, I think. So icodextrin is like a liquid. It's like an IV bag that you just swishel swashel the bowel with before you close. That's supposed to decrease adhesions too. But try Intraseed. It's actually marketed towards a gynecologist. So when
Okay.
GYN does all their like endometriosis surgery or pelvic exoneration, they put that down and it works really well. I went back in a patient with stage 4 endometriosis and
Oh
it
wow.
was like as if no one was there. It was so
Wow.
beautiful. So I've become a big fan of it, but you have to go to the GYN side of Ethicon and ask for them um, because they don't market it to general surgeons,
Hmm.
even though it's great. Let's see. Is mesh best removed by implanting surgeon or a super specialist such as yourself? Good question.
That's a good question. You can usually gauge by your surgeons by how apprehensive they are to take it out, whether or not that's the right person. So
That's so true.
they're like, if your surgeon that you go back to is, and you're like, hey, I have a problem, I really need this mesh out, and they're like, I don't really think we should do that. And then that's probably not the
Yeah.
person who you should force to take mesh out.
Yeah, don't force them.
Yeah, I mean,
Yeah.
some mesh, so again, getting into the weeds here, there's so many types of different mesh and so many different places to put it. So depending on what type of mesh you have in what part of the body, um, then uh, it can be easier or harder to take out. And so if you take the mesh out, I will say then there's a pretty good chance, not so much for inguinal. I'm actually shocked by how often when you take inguinal mesh out, people don't get inguinal hernias back. I feel like that hasn't been publicized enough.
Yeah, they eventually do, but yeah.
Yeah, well, maybe eventually, but it's
Yeah,
not as opposed to ventral, where if you take a
true.
ventral piece of mesh out, it's almost inevitable that you're going to get a
Yes.
hernia. So
Yes.
I would say, in the spirit of planning for the next hernia repair, you should probably give the surgeon that is going to eventually do the next hernia repair. You should probably give that surgeon the chance to take the mesh out so that they can decide what they want to do, how they want to do it.
True.
Because they're going to be thinking like, okay, I need to think of not just taking this mesh out, but I don't want to burn any bridges for next time.
Mm-hmm.
So I always like, if I'm going to be taking someone's mesh out and then also having to deal with the sequelae of that, I'd rather have been the person that took it out the first time. So
That is such a good point. That's a really, I mean, I never want to like impose on the patient to like force them to come back to me afterwards. Cause there are reasons why they may or may not want to come back, but I really do want them to come back because I kind of have, like you said, like plan A, plan B, plan C about what will happen and how I would address it based on what I've seen already in the OR in the mesh removal process.
yep.
And that's a good point. Do not force your doctor to do something that they don't feel comfortable doing. Yeah. Question, which antibiotic does Dr. Petro use to prevent infections in the seromas he mentioned?
Yeah. So again, I don't do that often, but I would say
All
for,
those seromas, all those
yeah, I
infected seromas.
know. So if and I'll just say like for um cases that are not involving like a stoma or something dirty, so clean cases, which is most inguinal, umbilical, ventral hernias. For surgical site infections or things where I'm worried about, I see a little wound cellulitis and I don't have a culture to go off of, and I just want to send someone home on something. I usually do doxycycline
Okay.
because for a few reasons. One, it typically covers MRSA, particularly here on our antibiogram. It's relatively safe. I mean, you figure there's like probably hundreds of thousands of teenagers taking doxycycline for acne across the country, and
That's
so
true.
it's pretty well tested. And I mean, the biggest reaction that you can have to it that photosensitivity, and in Cleveland we don't have to worry too much about that. So, but because of that, I'll either do doxycycline. Sometimes, if they couldn't do that, I might do Bactrim. Again, I think in today's world, you almost have to assume that a good chunk of folks are going to have MRSA or so, I tend to prefer to cover for that if I don't have a culture. Obviously,
Yeah.
if I have a surgical site infection and I've cultured that, but a common scenario is someone, it's their day, they're ready to go home, and their wound is just a little red, and I don't have a culture. I don't want to open up the incision, and I thought, and I'll just, I'll send someone on a week of doxycycline or Bactrim for wound cellulitis, and more often than not, my nurse practitioner will, message me a week later and say everything looks fine.
Yeah. The underlying message is you really want to cover for the MRSA bacteria, at least in the initial, um, because that's a bacteria you really should cover for, especially if they've been in the hospital before.
Yeah.
Um, so we talked a little bit about mesh complications, but this question is it's a pretty good one. As specialists, what suggestions or changes would you both suggest to help improve patient outcomes in the public sector if you could change the scope of surgical practices, i.e. guidelines recommending tissue repair for small hernias in suitable patients, but the gold standard appears to be that general surgeons are implanting mesh in every patient who presents with a hernia, which in my opinion is one reason for an increase in complications. It's kind of that whole tailored approach, just because a study says that there are better outcomes, let's
Yep.
say lower recurrence with mesh, does that mean every patient should have mesh? And how
Yep.
do you recommend that should be
So
disseminated to our population?
I could probably talk for 10 minutes about this, but so just cut me off if I'm going for too long. So
Sure.
um, the full answer to that. So the reason that we use mesh for incisional hernia repair dates back to a study that was done in the Netherlands. It's the Lyendijk study. It was published in the New England Journal of Medicine in the year 2000. It was for small incisional hernias less than 6 centimeters. And they took patients and they randomized them to suture closure alone, or they had to put a little piece of mesh with only 2 centimeters of overlap, and they didn't even necessarily close the fascia over top. And what they found with that was that the recurrence rates long term were much lower if you use a piece of mesh. To be true, if you actually look it up, the recurrence rate's actually pretty high in both arms,
Yes, it was pretty
but
high.
it's
It was
statistically high.
lower, but it
Yeah,
was pretty high still.
statistically high
It's like 40 versus 60% or something in that range.
correct. That data has been extrapolated to all ventral incisional hernias of all sizes. And the other funny thing is it actually hadn't been repeated to this day. There were other trials that tried to get it started, but never actually finished for a number of reasons. And so this is what we know. We know that based off the data available, it seems like mesh does reduce recurrence rates. The best data that we have available in terms of mesh complications is by Kokotovic. It was published in JAMA, and that they looked again at a large Dutch database, and they found that the mesh complication rate requiring reoperation is about 5% over the course of 5 years. Okay. And so we know that mesh reduces recurrence rates, but it also has some, degree of complication rates over the course of time. we also know that the technique that was used for that study doesn't really replicate what modern techniques are. And so, for instance, we know now that when you close the fascia with just suture, you should use small bites, small advancements, small needle. So the small bite 4-to-1 ratio, or the length of the suture has to be so long so that you know you didn't travel too far, and your bites have to be close together. And the idea is that a lot of things that are really close, like a zipper, is really strong, but it's
Yeah,
just a bunch of real tiny things. It's stronger than a button shirt because the button's really far away and you could probably just rip it apart. So that's the idea.
good analogy.
So again, and then for the overlap, they only did 2 centimeters of mesh overlap, which is again not what we do now. Now we get tons of retromuscular or preperitoneal overlap
Yeah,
and close the fascia on top. And so our opinion was that this study was way overdue to be replicated. And
true.
so we're in the middle of replicating it. And so we are doing, for hernias that are less than 6 centimeters, these are belly hernias, ventral hernias less than 6 centimeters. We're redoing it, and we're randomizing patients in the operating room to either getting a small bite 4-to-1 closure, and we're also cutting the posterior sheath of the muscle, because what we have found is that dramatically reduces the tension
Attention. Yeah,
on the closure. And so if you cut the posterior rectus sheath on both sides and you do the small bite suture technique, and then we're comparing that to a modern, what we would consider a modern retrorectus technique, where you put mesh in the retrorectus plane. And so we're in the middle of that trial, and the primary outcome is not recurrence. The primary outcome is the patient's quality of life at 1 year. Because I think that so often we get hung up on recurrence. And what is a recurrence? If you had a hernia that was this big and you have a recurrence that's this big, but it's there on the CT scan, but your quality of life is 10 times better,
yeah,
does that really matter? And so it's a very pragmatic trial in that we really want to know from the patient's perspective, because our guess is that patients will accept
yeah,
some degree of recurrence to not have a piece of mesh. And so we know that there's a mesh complication rate. We know that it's real. And so we just want to be able to give patients the best chance to really get what they want, which is, if you can get away without having a piece of mesh put in you and get the similar quality of life improvement, who wouldn't want that? And so it's actually a non-inferiority trial, and it's is no mesh not inferior to mesh in regards to the patient's quality of life. So if you're interested in no mesh repair, normally in the past I would tell folks that you're in the wrong place, but at the Cleveland Clinic right now today, you're going to be enrolling in our trial. We're trying to make it a multi-centered effort, and so we're in the middle of recruiting 3 or 4 sites, but we have to go through data use agreements and all that. So
that's great. So I have two stories to share for you.
okay.
One is the senior author for the paper that you mentioned,
Mhm.
um, uh, Johan Yickel,
Yep.
came to visit us at USC as a visiting professor at the county when I was at USC. And back then it was okay to like just bring someone into the surgery to operate. Like we got
To
paperwork.
operate.
Yeah, we got paperwork done, but like he didn't have to get like a license to do it, right? So he
Mhm.
was allowed to come in, and he gave grand rounds, and he met with the residents, and we're like, we found a patient for you. Why don't you show us how to do your beautiful incisional hernia repair with mesh? It was this kind of moderately obese Hispanic lady who had a C-section incisional hernia. So he came into surgery and said, and closed the defect, and we all scrubbed in like watching Yukil's operating, right? And he's like, you know what, this looks good, we're done. I said, wait, hold on, literally your research is the landmark paper saying you must use mesh in an incisional hernia. This is fine, look at it's coming. And I don't know if he was just tired and he's like, why the hell do you have me fly from the Netherlands and then have me operate, what the hell? Or if he truly was not practicing what he was preaching, which was that
No. Yeah.
and let me tell you, I it's the county system. I don't know what happened to that patient. I'm willing to bet that hernia recurred because she had all the risk factors for a hernia recurring, including I think it was 6 centimeters, and he just kind of put it together.
Yeah.
It looked under tension to me, but he's like, no, it's fine. So that's number one. The second is I'm 100% love that you're doing this research project because we need to be a little bit more innovative in how we treat patients and understand that a 6 centimeter hernia is different than a 1 centimeter hernia, which is different than a 12 centimeter hernia.
Yep.
And why they got the hernia and the quality of the repair, all that's important in the suture use. So being in Beverly Hills, I'm also very interested in figuring out alternative ways of treating incisional hernias because, like you said, the gold standard is to use mesh for all incisional hernias. So you had a surgery, you had a hernia from that will fail if you just close it again, just like how they originally closed it. So what we are doing, of course, it's a very limited population, but still it is a population, is people that are candidates for a tummy tuck. That means they have enough of a laxity of the abdominal wall to actually get a tummy tuck with the extra skin and everything else that comes with a tummy tuck. They will undergo primary repair of their incisional hernia, and the plication is treated as a permanent onlay autologous biologic. So you have the primary repair, right? So you're doing a primary repair.
Yeah. Yeah.
But the plication that is done as part of the tummy tuck, which is the extra second layer closure, is a permanent onlay biologic,
You're
autologous
right.
biologic.
Honestly, someone came to see me probably it's been in the last year, and they told me that someone told them that, and I just sat.
You laugh at them?
I didn't laugh.
What a quack. Who
But
said that?
wow. I thought, but I considered it, but to be honest, I had not heard anyone describe it. But you're right. Like, why is that not an onlay? Why would that not decrease the tension on the closure or offload the tension
Okay,
on the closure?
it's not for a 10 centimeter hernia. So we
Yeah,
started
but
small, right? We recruited
100%.
patients
Yep.
and, you know, we started small. So 1 centimeter worked, 2 centimeter worked, three, we went up to 4 centimeter. We're now 5 years out with some of our patients.
Mhm.
They worked. Last weekend, I did an 8 centimeter hernia and the plastic surgeon was like, we can do this as a tummy tuck. And I said, no, 8 centimeter. She's had two incisional hernias before.
Yep.
Um, I take that back. She has had two laparotomies and both had incisional hernias and just closed it again.
Mhm.
But she had diastasis, multiple children, etc. Thin lady. I'm in Beverly Hills. Remember that my patient population is definitely different, at least the local ones. So thin lady, very fit, super lax abdominal wall because of all these surgeries and the whatever. So I said, I will have an open mind because we are in this learning phase.
Mhm.
8 centimeters sounds a bit wide to me. So we took her to the OR, we put her under general anesthesia. And let me tell you, it was no longer 8 centimeters. It was like 5 almost. That came together so perfectly. Now I'll follow her, obviously. She's in our catchment group. But we're kind of I think 8 centimeters would be too much, but like she really was in the OR, she was 4.5, almost 5 centimeters wide. And we'll see how that goes. But this idea that every single patient needs a mesh, we're starting to throw out.
Yeah, I think we got to open our mind, like you said. And the implications, let's say what we find is that, our quality of life is no different. Well, then, I could probably even spare the folks the laparotomy and do that robotically. And again, cut the posterior sheath and
Close
just
it.
bowl closed, and spare. Now you could do the same thing with small incisions. So
Yeah.
the downstream effect of, if we start to realize what scenarios, we can get away from using mesh, I think it definitely, I think we, like you said, we just have to open our mind to what else is possible.
Yeah. Let's get through some more of these live questions. I'm glad there's so many. Let's see. If a patient has cardiovascular disease, stents, 60% blocked aorta, and has developed several ventral hernias and a number of inguinal hernias, what precautions and disciplinary team would this patient require for the best possible outcome? I'm referring to my brother who now has a fear of mesh complications after witnessing my experiences.
So I'm really lucky that I just have the best cardiologist in the world at the Cleveland Clinic, and I could
Yeah,
just
you really do.
and all I need to say is, can I operate her? And then once I operate, just make sure I do a good job. But like if they say that they're ready, and really it's not even, sometimes I think patients are waiting for someone to say it's not a yes or no, it's a risk stratification. And so they just explain to them like you're this risk, or this risk, and then it's optimizing and making sure there's nothing else you can do ahead of time. So I am fortunate in that part. I will let the cardiologist dictate the risk question, and then I just make sure I do a good job in the OR.
True. Yeah, that's true. I always say life before hernia, right? Like,
Mhm.
in patients that are higher risk, like you don't want the perfect hernia repair. You
Mhm.
just want the one that doesn't kill them, or, improves their quality of life. And that's where that study came from of the watchful waiting trial, not the watchful waiting trial, the whether hernias that are loss of domain and 9 centimeters or greater should be repaired, is
Mhm.
they found a significant improvement in their quality of life, even if it's not a perfect hernia repair.
Yep.
They do so much better than having a huge 9 centimeter hernia baby to like, you know, walk around with.
Yep.
Um, let's see. Thank you, doctors, for that valuable information. I am providing this information to relevant ministers. Oh, this person, I believe, is from Australia, along with requesting our government to be the first country to introduce an abdominal wall specialty or speciality, as is being suggested by the American Hernia Society. Until that can be implemented, I am looking at changing the scope of surgical practices. Thank you again. So yeah, there's some interest in pushing doctors, surgeons to be actual specialized in hernia surgery. And of course, that involves that whatever the society or board is to actually identify hernia as a specialty. What are your thoughts on that?
So the Fellowship Council opened or invited a handful of places to make a fellowship spot with an official designation as a hernia fellowship. And I think they
Mhm.
invited, I can't remember, 5, 6, 7 places, but only two play us and one other place ultimately did it. A lot of the places are kind of unaccredited, which is what we were. That mine was unaccredited outside any fellowship designation. And when you do something like that, it sounds great in theory, but it requires a lot of details to sort out in terms of what does it mean to be specialized in abdominal wall reconstruction? How many cases does that take? Like I know at our fellowship, it's robot, open, peristomal, TARS, redo TARS, managing chronic groin pain, foregut,
Yep.
paraesophageals, redo
You
paraesophageals.
need that variety.
Yeah, and so like it's a lot, and like not every place is going to be able to accommodate all of that, and
Yeah.
and so it's hard. We're sorting it out. We actually coincidentally just interviewed our first batch of applicants yesterday, and we have one more round to go. So we are just getting started here. There are, I think, like I said, 2 programs followed through, and so there are 2 programs this year that are going to be kind of ab wall fellowships officially with that designation with our fellowship council. And so hopefully within,
Who's the second group?
I think Penn State.
Mhm.
And then there's other ones. They're just not ab wall
Not
specific.
accredited.
Ab wall and bariatrics or some foregut or something
Yes.
like that. So there were only 2 that were kind of just focused on just ab wall.
Yeah.
And so there are other ones that are kind of informal outside the match that are just kind of like through phone calls and things like that. But um, hopefully, we want to be invested in the council. The reason we joined is because we want to be at the table when the sorting out what those numbers look like for what it means to be an ab wall specialist. And so hopefully we'll move things along, and so that other places can follow. Hopefully we will have more information on that in years to come.
And do you expect people that train with you then to go out and like develop their own hernia program, or are you hopeful that
We
this
just want
kind of
them.
that this will be like an actual widely sought after general surgical specialty?
We just want them to go out and just be good stewards of
Mhm.
of what we've taught them. And what's really fun about this year is I'm pretty sure both our fellows this year, we have two, are going to be paired up with two of our previous fellows, and they're both considering taking a
Oh,
job. They're like 2 or 3 years apart. And so
yes.
that's going to be really fun because now with two surgeons, two of our former fellows working at the same spot in tandem, they can now have their own fellowship. And so then we can be like grandparents and we can just like
Yes.
talk
That's
each
so
other.
lovely.
Yeah, I'm really excited. I hope it kind of ends up that way. They've got really good opportunities.
That's really great. It's so nice to see people that you've trained go out there and be the person you now refer to or that are training others and they kind of take a little bit of your philosophy over to
Yep.
wherever they go. So the legacy continues. That's really, really nice.
Yep.
One quick question before we leave. Do large rectus diastases or large ventral hernias cause nausea or feeling sick to the gut during many types of physical therapy? Also, after a repair of such a large ventral hernia, does the sickness and nausea issue usually go away?
So I'll withhold my bias and I'll say that I don't think that it's studied well enough.
Okay.
I think that we have shown that we can fix diastasis in terms of the long-term follow-up and what the patient benefit is of that. I don't feel like, and again, I'm looking at it from a general surgery perspective, sure, and you probably have more of like the plastics, perspective on like, their types of outcomes in terms of
Yeah.
what they can benefit. But I think that my perspective on this as a general surgeon, not doing big abdominoplasties, is there's been a big push to plicate diastasis during hernia repair, where there
Yeah.
might be a small hernia within a diastasis, and the patient wants the whole thing plicated. Or there are other techniques where you can go just on top of the muscle, the scola, and you could just plicate it.
Yeah.
And so what I have found is that usually you are trading, if they want it done for cosmesis, I often tell them what I have found is that you are trading one cosmetic problem for another, because if you don't do the concomitant abdominoplasty like you do, Sharon,
The skin part. Yeah.
you're just getting a
Horrible.
tissue bulge, and it
Yeah.
just doesn't look
Horrible.
great. A lot of times
Yeah.
it just flattens out with time anyway. For the folks that attribute the diastasis to other types of GI symptoms, my experience again has been that the two typically are not related. You can have a diastasis and GI problems, and the two might not be, associated. I will tell you that the textbooks would say that diastasis should be considered an asymptomatic type thing that is purely cosmetic and that can't necessarily cause hernia type problems. Has that been your experience, Sherwin, or not necessarily?
Pretty much. Yeah. Pretty much.
Yeah,
Yeah. But sometimes it's not really a diastasis. It's an incisional hernia
correct.
and it's
Yep.
misinterpreted as a diastasis.
Yep.
Yeah. Okay, well, thanks so much for your time, Clayton. I so appreciate it. It was really fun. Tons of questions. There are many that I wasn't able to answer. I'm sorry.
That's okay.
Um, but we are running out of time. So
All
it
right. Very good.
I'm already very grateful because you're many hours ahead of me. And so it's getting dark where I am. So I appreciate it's already dark where you are. And
Absolutely. We
you're
appreciate
with family. So thank you so much for your time. And thank you everyone else for participating. Do watch this and share this episode with everyone. Follow me and subscribe to my YouTube channel at HerniaTalk. And also don't forget to write a positive review on the podcast station. So that'll really help the algorithm. Thanks, everyone. See you all next week for another episode of Hernia Talk Live on Tuesday. Thank
All right.
you.
Bye.
Bye.